everybody. Thank you for joining me here today. My name is Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation. And since the end of March, CPBF is hosting online education sessions for families of babies born preterm right here on Facebook. Every Monday and Friday, 1 p.m. Eastern Time, I'm bringing specialists, researchers, and parents of babies who spend time in the ICU to share their experience, their expertise, and bring the information that you might not have wide available now, that a lot of clinics have been closed and most appointments have been virtual appointments at this time. And always you can send your suggestions and talks that you would like to see us addressing here on Facebook. You can always send us a private message. And today you can ask questions and make comments on the box below. Today we're going to be talking about brain health in the preterm baby and the importance of every day. We're going to be addressing neonatal pain, sedation, and nutrition. I have the honor to be talking today with Dr. Stephen Miller, who is the head of the Division of Neurology and Center for Brain and Mental Health at the Hospital for Sick Children here in Toronto. He's a professor of pediatrics at the University of Toronto and the senior scientist in neuroscience and mental health program at the Research Institute of SickKids. He holds the Bloorview Children's Hospital Foundation Chair in Pediatric Neuroscience. Dr. Miller and his team focus on improving the clinical care of newborns requiring intensive care, such as those born preterm or with congenital heart disease or born preterm. Findings from his research program inform new strategies to promote optimal brain development and neurodevelopmental outcome. Most recently, he co-directs Child Bright, an innovative pan-Canadian network that aims to improve outcomes for children with brain-based developmental disabilities and their families through Canada's strategy for patient-oriented research. Dr. Miller, welcome, and thank you so much for joining us here today.
Thanks so much for having me, Fabiana, and congratulations on the important work of the Canadian Premature Babies Foundation. It's really wonderful to be here with your team for this conversation about the brain. I just wish that we were doing this all in person so that it could really be a conversation. Before launching and making the introductions, you had asked me some questions about, why get interested in the brain? And I have to say that for me, this has been a 25-year journey, getting interested in the mysteries of the brain. Barack Obama, when he was president of the United States and launched the Brain Initiative, I think said it very well, that we've reached a point where we can land a person on the moon, and yet we understand so little of that 3.5 pounds of matter between our ears. And there's something about that mystery that's exciting, that has propelled us forward over the last years, and I hope to share some of that excitement with you and your team. So recognizing that 90% of what we know about the brain, we've just learned in the last 10 years. I hope you'll all join me in some forgiveness that we still have so much left to understand about the brain, and even more left to understand about the developing brain. So with that, why don't we start to take a look at brain health in the baby born early, the baby born preterm, a condition that all of you are even more familiar with than me.
Thank you, Dr. Miller. And your passion really speaks, through your words and through the work that you do. And for people who have watched our lives before, we're going to do a little bit different today. Dr. Miller is going to do a presentation on the brain, and at the end we're going to ask him questions, so you can type your questions and comments below. So thank you all. Thank you, Dr. Miller. Go ahead.
Thanks again, Fabiana. So as a physician scientist who uses brain imaging to try to understand the issues of the brain in babies born early, I do think that pictures are worth 1,000 words. And so let's start by looking at some pictures of the brain. And these are MRI scans that were obtained from a baby who was born 3 months early. And so imaged at 2 weeks of age, and then again 9 weeks later. So if we think about full term being 40 weeks, we have an MRI scan that was obtained at 30 weeks, and then again at 39 weeks. So just so that we're all oriented to the images, it's as though we've taken off the skull and are looking down on the brain. So the front of the brain, you could see by the red pointer over here. The back is over here. And to keep things confusing with brain imaging, we reverse right and left. So we have the left side and the right side. Let me draw your attention to this dark line of gray that's going around the surface of the brain. So here we have the skull, and then we have this dark ribbon that we could trace all around. It's very smooth. And this dark ribbon is the cerebral cortex. And just like an adult cerebral cortex, there are about 15 billion nerve cells in that cortex. So we call nerve cells in the brain neurons. So about 15 billion neurons in this cortex, even at this stage of development. And the cerebral cortex overlies the brighter area, the white matter. We can make out here the regions that we call the basal ganglia and the thalamus, the relay stations of the brain. And this white matter are the connections between the nerve cells, the neurons in the cortex, and in the relay stations, the basal ganglia and the thalamus. The other bright areas are the ventricles, the normal fluid-filled spaces of the brain. So we start at 30 weeks, and then the same baby comes back to the MRI scanner 9 weeks later. And so tremendous thanks to this family for coming back after they've left the NICU to volunteer for these research studies so that we can look at these images of their baby's brain and just look at how the brain has transformed over only 9 weeks. So let me draw your attention back to this dark ribbon, the cerebral cortex, and look at it now. It's no longer smooth. It's lumpy and bumpy with sulci and gyri. So imagine if we were looking up and down in the brain now. This brain at 39 weeks gestation would look just like our brains in 3 dimensions. That sulcated, gyrated, lumpy, bumpy structure that sits between our ears. Why does the brain make these sulci and gyri? Well, we have these 15 billion neurons all vying for space, looking to make connections. And as they make connections, they need more room because the connections are taking up room. So in order to fit the cerebral cortex in within the skull, it starts to fold and make sulci and gyri. We still see the white matter. We still see the relay stations, the basal ganglia, the thalamus, and we start to see fat being laid down in this part of the brain. And these are our voluntary motor pathways coming from the top of the brain down through the spinal cord. So just an amazing period of brain development, all of this transformation happening over just 9 weeks. And what's so remarkable as a clinician about this process to me is that this baby spent 6 of these 9 weeks undergoing neonatal intensive care. Now, when I started training as a pediatric neurologist, we were taught to focus on the big event issues that would happen in babies. That might be because the heart stopped or because the baby had seizures. And fortunately, with tremendous advances in newborn medicine, those big events are just increasingly less common. And so over the last decade, we started to ask, I think, more refined and more important questions about how does the everyday experience of this baby influence this incredible period of brain development? And that's what I'm going to term for this talk, the importance of the everyday. Now, anybody that spent any time in the neonatal intensive care unit, whether a baby was born preterm or full term, but a baby requiring newborn intensive care, knows that part of the everyday experience of babies in the intensive care unit are issues of pain, analgesia, and sedation, so medications to ensure that pain is treated and babies are comfortable, and then nutrition. I realize that there are many, many other everyday experiences that these babies go through. But in speaking with Fabiana and in her sharing some of the interests of your community, we thought we would focus the next minute on just these 3 areas. So it's not to say that the other everyday experiences of babies don't matter. We're just going to focus on pain, sedation, and nutrition. So after training as a newborn neurologist in San Francisco, I was fortunate to move to Vancouver and found myself in an office a few doors down from Dr. Ruth Grunow, a developmental psychologist who has spent her career studying issues of pain in babies born preterm. Now, Dr. Grunow had shown over decades of studies that the greater the exposure to pain, and here she means procedural pain, poking for an IV, needing a ventilation tube, having a chest tube, not the subjective experience of pain, which is very hard to tell in a baby born early, but procedural pain, what I might call skin-breaking procedures. What she had shown is that if you look at how much pain a baby was exposed to, that related to their developmental outcomes, particularly things like internalizing behaviors, so the degree of anxiety, issues like attention, even when you accounted for how ill the baby was and how much medications the baby had to treat the pain. So that issue of illness is important, so let me stress that any clinician I've spoken with, the nurses, the respiratory therapists, the physicians, we would love to be able to provide intensive care without pain. These babies are having pain as part of their intensive care to treat their medically significant conditions. So in speaking with Dr. Grunow and being a straightforward neurologist thinking about the brain, it stood to reason that if a child's development was different, then there must be something different in the brain. And so we set out over the next, still going, but over the last 15 years, to try to understand how does the exposure to pain as a preterm baby influence this incredible period of brain development. And to start to answer these questions, we had to move from these, I think, beautiful images of the brain to start to quantify the images. And for our conversation, I'm going to focus on the volumes of the brain, so the size of the brain. And let me be clear at the outset that size isn't everything. So larger brains don't necessarily mean better outcomes. And certainly within children who aren't born preterm, the size to outcome relationship doesn't really hold. So please don't go looking at the size of everybody's head that is in your home with you now or that you're meeting in the streets. We're using size and volume of specific brain structures to really try to probe the maturation of the brain over this period of development. What we had seen over our initial studies was that how much pain you were exposed to as a baby predicted how rapidly your brain developed as you went from scans early in life in those first weeks to those scans being done roughly near the baby's due date. And we had seen these changes that using sophisticated statistical modeling held up as an independent relationship between pain and the brain, even when we accounted for the illness that the baby was being treated for and how much medications the baby was receiving to treat their pain. So let me be cautious that in these types of studies, we can't prove cause and effect. We're merely looking at associations. So the association between more pain and less robust brain development. Now, when I was training as a pediatrics resident in Montreal, at particularly, at places like the Royal Victoria Hospital, a pioneering center for neonatal intensive care, it wasn't that long ago, we were still arguing or discussing, do babies born preterm really even feel pain? And that was because when they had a painful procedure, we often didn't see the signs of pain that we're used to seeing in older children, grimacing, crying, changes in their behavior. During my training, it became clear, and no one doubted, that babies felt pain. But to our community, the idea that pain itself might be associated with how the brain was developing seemed almost surreal. So fortunately, at scientific meetings, what makes these meetings so valuable is we get to hear people's questions, and we get to, through those questions, get to push the science further. So when we looked at the data in even more detail, we saw that this relationship between pain and the brain was most evident in the very preterm babies, so particularly younger preterm babies, and it was particularly relevant for pain that was happening early in life, so before their first scan. And that's important because it gives us a clue as to where we need to target our pain prevention strategies. One of my mentors, Dr. Donna Ferrero, a leading neonatal neuroscientist from the University of California, San Francisco, said, I buy all of that. But there's also neurophysiology data using tools like electroencephalography that suggests that the transmission of painful signals up to the brain through the thalamus, the region of the brain that is the brain's relay station for all of our sensory input, wasn't gating these pain signals appropriately. And so we wanted to ask, perhaps if pain is important for how the brain is developing, we should target our efforts to look at the thalamus. Now, I mentioned the thalamus is the relay station. It's important not just for sensation getting up to the brain, it's important for our vision, our hearing, for connecting different brain regions. And so working with Emma Dorden and Jesse Guo over several years to refine how we map the growth of the thalamus, we saw that greater pain in the neonatal intensive care unit predicted slower growth of the thalamus, particularly in those regions that were important in the thalamus for relaying sensory information. So not the vision part of the thalamus or the hearing part of the thalamus, but it started to add some specificity to the conversation. And this is what really, I think, elevated the conversation amongst the neonatal neurology community to say, we really need to pay more attention to pain, because with imaging, we're able to see these changes even more robustly. And let me remind everyone on the call that when we map out skin breaking procedures, the range is from very, very few close to zero to almost 300. So we're talking about a large number of painful experiences. And this gives me hope that by decreasing painful exposures in the NICU, we'll have room to move this curve back to this end of the relationship, seeing less of a relationship between pain and growth of the brain. Now, I mentioned that we now recognize that preterm babies feel pain. So we want to prevent pain, and it's been very gratifying to see as our studies have rolled out over time that number of painful experiences is coming down. People are becoming more attuned and looking for more and more opportunities to prevent pain. We also want to treat pain, and we use that using medications for analgesia, pain prevention, and sedation to keep babies comfortable. Well, one of the advantages to moving intensive care units, I went from San Francisco, I trained in Montreal as a neurologist, went to San Francisco, then Vancouver, and now back east to Toronto, was to see how analgesia and sedation practices differed considerably across these units. And one big difference was the use of midazolam. This is a medication that's related pharmacologically to Valium or diazepam, Ativan or lorazepam. Midazolam is a medication that's used intravenously. It's used safely, and it provides very effective sedation for babies who are going to be on a ventilator for a long period of time. And there were experimental studies suggesting that midazolam might impact the large neurons of the hippocampus. The hippocampus is a seahorse-shaped structure deep in the brain, and it is critical for how we form memories. So if you remember anything of this conversation today, it's because the neurons in your hippocampus have formed some connection. And so because of this neuroscience literature linking midazolam to the hippocampus, we wanted to ask, does midazolam use predict growth of the hippocampus? Well, the hippocampus is this small seahorse-shaped structure that's so small it took us and many other groups years to work on how to refine the imaging measures so that we can get sensitive measures of the volume of the hippocampus. Because we were imaging these babies born early, early in life and then again at term equivalent age, we could look at the growth of the hippocampus in millimeters cubed per week. And in those babies receiving midazolam, we see slower growth of the hippocampus with greater doses of midazolam, even when we account for their lung issues, infections, pain, and other aspects of the illness, suggesting some link between midazolam and growth of the brain. And so this has caused us to pause and ask, how and why are we using midazolam? There are times, I want to make it clear that there are times where midazolam is necessary for the baby's medical care, but it's prompted us to start to ask, how do we provide sedation and analgesia that's effective not only for the comfort of the baby, but also could be provided in a way that promotes most optimal brain development. And through several other studies with several colleagues, both in Canada and elsewhere, we've seen the most specific relationships between pain and the thalamus, midazolam and the hippocampus, morphine, commonly used for analgesia, specifically with the cerebellum, and then working with colleagues in Lausanne in Switzerland who don't have access to sucrose for analgesia, so they use glucose for analgesia, oral glucose, we see links to the basal ganglia. And so this has caused us and others to ask, so with all of this information about what's influencing the brain, what's the best strategy for pain management? We don't think that it's going to be possible to do randomized controlled trials of each of these medications because there's so much going on in the intensive care unit. So instead, with colleagues across Canada, BC Women's Hospital, NICU, Mount Sinai in Toronto, and SickKids in Toronto, and with support from the Canadian Institutes of Health Research, we've been taking advantage of the variability that exists within centers and across centers to start to look at these brain images to say, okay, we have these relationships, but what's best for the brain? So hopefully you'll have me back in a few years and I'll be able to share the answer, but forgive me that this is still a work in progress. We're still learning. So that's pain, analgesia, and sedation. What about nutrition? Nutrition is something that parents and healthcare providers think about every day in the NICU. Julianne Schneider, who's a neonatologist now in Lausanne, spent a few years with us as a fellow at the Hospital for Sick Children. And she came with data from the Lausanne cohort, a group of 49 babies born preterm who had MRI scans in the first week, a few weeks later, and then again at their due date. And working with her colleagues like Anita Treatman, a wonderful group of neonatologists, they carefully mapped out exactly how much nutrition these babies had in the first 2 weeks of life. So this is nutrition just for the first 2 weeks of intensive care. And what we see is that the greater the calories the babies received, the more lipid the babies received, and even the more protein the babies received, related to how well the brain grew over these first 3 scans. So seeing a strong relationship between energy, lipids, that magnified over time. And this is quite remarkable to think that what happens in your first 2 weeks of life might have an influence for how the brain is maturing over the next 10 weeks or even 15 weeks. And so we and many other groups around the world are now looking at how we could use nutrition in ways that promote the most robust brain development over this time. And this is very exciting to me. I started my career doing brain imaging, thinking that we were going to set up a model for brain protection drugs that we could use. This is saying that we have things that exist today in 2020. How could we learn to use these in a way that promote not only the best growth of the baby, but the best growth of the baby's brain? Also, can we use them to help us mitigate early exposures that we know aren't beneficial to the brain? So we've learned through several studies from several groups, not just our group in Canada, that the longer you're on a ventilator to support your lungs, the slower the brain is growing over time. working with Julianne and her colleagues, we looked at this in this group of 49 babies to see that in babies who need more ventilation as a sign of higher lung disease, their brains are growing less rapidly than those babies with lower ventilation needs. Unless the babies received high calories in those first 2 weeks of life, we see an opportunity to shift that curve. I mean, today with COVID, everyone's talking about flattening the curve. Here we want to ramp up the curve. And so look at how high ventilation needs and high calories looks no different from those babies with low ventilation needs. So how do we start to use what we have access to in 2020 to promote early brain development? And to me, this is really the power of MRI. It's not just about having these beautiful pictures. It's not about looking for brain injuries. It's about identifying opportunities to care for babies in a way that best support their brain development. Okay, so where do we go from here? You know, one route that the community is taking is looking even earlier. What's happening to the brain even before these babies are born? Let's take a few slides to look later. This is now the same baby brought back to the MRI scanner 8 years on. And I said it at the beginning, and let me reiterate just how grateful we are to these families for contributing to these studies, not only over these very stressful weeks in the intensive care unit, but for years afterwards. And there's no way we would have any of these insights without the support of this community. Now look how the brain has transformed again. This beautiful dark ribbon of the cerebral cortex, remember billions of neurons making trillions of connections overlying the brain's white matter. Now this is all insulated. So all the wiring of the brain is insulated by a fat, so it looks dark and the cortex is bright. So not only is the brain bigger, it's transformed once again. Now Antinis, who has run the neonatal follow-up program at British Columbia Women's and Children's Hospital for many years, has always pushed me to think about brain protection that doesn't end at the intensive care unit. It should go on even longer. So what if we start to look at follow-up as another opportunity for brain protection? Now, I had mentioned that Dr. Grunau in her studies had shown, this is not brain imaging, but she had shown that higher skin breaking procedures, more internalizing behaviors, and here higher scores is more concerns. This is not concerns needing a physician's input or a psychologist's input. This is just more issues around anxiety and attention. Jill Vinal, who was a PhD student with us and is now a faculty in Calgary, recorded largely moms and babies doing tests in the neonatal follow-up program. This is a shout out to dads. Please come to follow-up clinics because we really need to learn more about father-infant interaction. I've called it parent-infant interaction, but it's mostly moms. And what we see is that with more, this is a scale, so excuse the words, but more optimal interactions. This is not a judgment. This is just how things are rated on the scale of the emotional availability scale. We see a blunting of this relationship. So as these interactions get more optimal, you see that painful exposures matter much less. So this isn't about what's happening in the red line. This is about what's happening in the blue and the black lines. How can we help families in follow-up interact with their children in ways that help promote their child's development? And this is a question that as a neurologist, I am asked every day by parents that I'm in the clinic. And while this doesn't have the answer about how to do it, it suggests that there's something to go after here so that we could use our follow-up clinics not just for the important role of assessment and understanding, but for teaching and supporting so that we could shift this curve so that these early exposures, that everyday experience just matters less. And that answer is going to come not just from the intensive care unit, but it's going to be very important how we support children and their families, their parents, through the years of childhood. And looking from early in life to 8 years of age is something that we're currently working on in these studies with Dr. Gruner and our teams at these centers and with the families who are being so generous to stick with us over these years of these studies. So Most people see a neurologist and they worry about brain injury or something concerning. I hope that you leave this conversation with a neurologist thinking about hope, that by promoting brain health in the preterm newborn, by asking the question and looking at the brain, I am confident that we're going to have new opportunities for better outcomes. And with that, let me stress that none of this work happens alone. This happens as part of a large team that had to have been pre-COVID. This was from last summer, and it brings together people from multiple disciplines, not just physicians, nurses, psychologists, researchers, imagers, together for this work. Again, let me thank the parents and families who participate in these studies, our sources of support, and to you, Fabiana, and your team for having me this afternoon.
Oh, thank you, Dr. Miller. Absolutely fascinating. And you are one of those doctors that are so good at giving hope to families. And you know, you were my son's neurologist when he was first diagnosed with cerebral palsy. And you were the only doctor who always said to us, you have to do what is best for your family. And I have so much gratitude to you and the work that you do and how much you support our families in the community is absolutely amazing. And yes, we will bring you back in a few years from now to see what else you've been learning and sharing with this community. I do have a couple of questions from our live audience, and it comes one from the Netherlands, actually. What could be adverse events of going through pain as a preterm baby, and how affects this the daily life of preterm born adults?
So that's a good question. I think we're just starting to scratch the surface through these and other studies to look at these painful procedures and how they relate to the brain. Our studies are really in their infancy when you think about development through adulthood. So over the last years, we've been fortunate to work with families to look at a child's development through age 8. And as an example, what we see is that the relationship between pain that I've shown you, midazolam that I've shown you, neither are in fact the same between boys and girls. And we see more and more specificity between the parts of the brain that might be influenced and the outcomes of the children once they're at school. I'd point you to studies by Chiara Nozzardi, as an example, who works in psychology in London, who has looked at adults who have been born preterm. And I think following those themes of increasing specificity, there's also, I think, themes of hope, where we see these changes in the brain really being modified by the exposures that these adults had through their childhood. And so I think there's lots of opportunities we have to support children and families to make these early life exposures less relevant for how they develop in the longer term.
Okay, one more question. Could there be some positive effects, such as better tolerance for pain in later life?
Oh, so I think that's a hard question. I'm going to preface my answer by saying, now that we recognize that babies feel pain, we want to prevent pain. And when we can't prevent pain, we want to treat the pain humanely. There is some work that's looking at babies born preterm and their sensitivity to just sensory issues later on. And the data that I'm aware of would suggest that you actually become more sensitive in relation to how much pain you had rather than pain tolerant. Now, and I've heard two sides of the story from families. Some babies that I see or that parents ask me never flinch when they get a needle for a vaccine. Others, the needle seems very, very painful. So we have so much left to learn in this area.
Well, there's one more comment on that. I was born at 24 weeks, was on vent for a while, had a PGA ligation. Oh, so many questions are coming. Sorry, it's popping on my phone now. So had a PGA ligation, collapsed lung, chest tube, heel pricks, etc., among other things. They actually asked my parents if they want me to have pain meds after PGA ligation. As an adult, I seem to have a higher pain tolerance, except when I stub a toe or something. I also experienced dissociation, not 100% related to being born early. And I was curious if general dissociation in relation to pain in former preterm babies had a correlation and is something that has been or could be studied.
So you make a number of good points. So it is something that's being studied both in people There are also pain scientists like Simon Beggs in London, who's looking at experimental models to understand how these early exposures influence your response to pain much later in life. Your question, though, is a good reminder to me to stress in this format where I can't see you and your response to some of these data, that here we're looking at differences across groups. I would never use these data to point to this is the number of pains, and so this is the outcome, whether it's sensation or other aspects of outcome. This is looking at groups of hundreds of babies that are born preterm to try to distill these relationships. Please don't interpret any of this as so many pokes in one baby means something. There are so many factors within an individual that influences this. At this stage, we're really looking at these group differences, and you've pointed out a few things that are absolutely worthy of future study, and I know several groups that are pursuing this. If this becomes an interest of your community, I'm happy to recommend some names to Fabiana offline.
Thank you. And one last question. Do you study the use of breast milk and skin to skin as pain relief?
Oh, great questions. And, we looked at some new devices that are based on AI to see if we can quantify how much skin-to-skin babies are having. And the technology hadn't been at the stage where we looked at this study, for this study. So we've been looking at breast milk primarily from a nutrition perspective, and we hope to look at that in our analyses of pain to outcome, but not specifically. We focused on the pharmacotherapy, not because it's the more important route, but because it's very well quantified by the nurses and by the doctors, and we could use pharmacy records. I keep my eyes open for ways that we could better quantify the skin-to-skin experience, something that parents ask all the time. And as we look towards more patient-engaged research, this is a question that keeps coming up. And I think breast milk holds similar interest.
Okay, thank you, Dr. Miller. Our time is up, but I guess we have to bring you back. There's many more questions that parents had asked us before that we could address in another Facebook Live. So thank you so much for your time today.
Thanks so much for having me.
So, and thank you everyone for watching us today. We'll be back on Monday, and Monday we're going to be talking about Zero Separation, a new campaign launched by GLANCE, which is the Global Alliance for the Care of Newborn Infants. A lot of parent organizations from all over the world are coming together to do a call to action to keep babies and parents together in the time of the pandemic. And every Wednesday at 1 o'clock Eastern Time, Kate Robinson, who is a psychotherapist and also a mom of 2 preemie girls, is hosting a real-time peer support groups here also on Facebook. And to access the link for that group, you can join the Canadian Preemie Parent Support Network, which is our private Facebook group. So thank you so much and have a good weekend, everyone. Thank you.
Have a good weekend, everyone.